Hello, my name is Michael McDowell. I am a PGY7 at University of Pittsburgh. Thank you for the opportunity to present our research on the use of dural sealants in skull-base surgery. These are our disclosures, which are not related to the topic today. So postoperative cerebral spinal fluid leak remains a major and also the most common complication after endoscopic endonasal surgery, especially those of an expanded nature. The general consensus is that a vascularized pedicled flap, such as a nasal septal flap, is the primary reconstructive method for high flow leaks. However, there's discordance in the use of tissue glues such as Tisseel or Duraseal in terms of efficacy and cost. To just briefly review our strategy for reconstruction, for patients without an intraoperative cerebral spinal fluid leak, we typically either do a free mucosal graft or in some cases nothing at all, such as with a Rathke's cleft cyst. We will not be focusing on this group today. For patients that do have a cerebral spinal fluid leak, it becomes a matter of high versus low flow. In the terms of low flow, such as a little bit of weeping after a pituitary adenoma resection, we again revert to mucosal graft. If it's a little bit more robust, or if there's intra-arachnoid dissection, we then prefer to consider the location of the defect. For cellular region as well as supracellular region tumors or lesions, we do use nasal septal flaps. If it is a supracellular region or supracellular expansion lesion, we add a collagen inlay. For anterior fossa lesions, we do a combination of collagen inlay, fascia lata, and nasal septal flap. And for posterior fossa lesions, we add fat graft to prevent pontine herniation syndromes. Here's an example of an anterior skull base reconstruction and a posterior skull base reconstruction. Here's just a quick video demonstrating a posterior skull base reconstruction. So here's the collagen inlay, followed by a fascia lata graft. This was for chordoma. We then add a nasal septal, we then add a fat graft. And then lastly, we add a nasal septal flap, as you can see here. Recently, our institute did a randomized controlled trial looking at the use of lumbar drainage in endoscopic skull base surgery, and we really were able to nail down specific indications for its use and its efficacy, specifically for large defects of the anterior and posterior skull base, but not necessarily for general use. Another thing that we frequently had used in the past is tissue glue, such as Tisseel and Duraseal. And the question then became whether or not this was effective given the advances in lumbar drainage technique as well as general reconstruction advancement. We hypothesized the answer was no, and then proceeded to do a study investigating this. We performed a prospective observational cohort study consisting of 300 consecutive patients undergoing endoscopic endonasal surgery from April 2017 to June 2019. We had 150 patients where we had sealant used, and then the next 150 patients we did not use sealant. We used a standardized reconstruction and lumbar drain protocol for all of these people within this group, as we just discussed. And we only included patients with an intraoperative leak. So patients with a Rathke's cleft cyst that didn't leak or in a small adenoma, they are not being considered. Only patients with a true intraoperative leak. So overall, there were 30 leaks within this group, postoperative leaks. In the no sealant group, there were 9 leaks. And interestingly, there were actually 21 leaks, more leaks than in the sealant group, or the no sealant group, when sealant was used. So this then raised the question, is this due to some confounding variable? Looking at a cohort comparison of the two groups, we see that chordomas and posterior fossa lesions were more common in the sealant group. However, when looking at the actual number of CSF leaks within chordoma and posterior fossa lesion, they were essentially the same. And obviously posterior fossa lesions are being driven by chordoma. Okay, so looking at a multivariate analysis of these factors, we see that it is actually, or that the use of sealant is significantly associated with a higher rate of postoperative CSF leak, independent of tumor type, independent of tumor location, and independent of lumbar drainage. A co-variable that was also independently and co-associated was high flow intraoperative leaks. But even in the presence of high flow intraoperative leak, sealant appeared to be also a significant factor in the subsequent risk of postoperative cerebrospinal fluid leak. So in conclusion, perioperative sealant usage did not reduce the rate of postoperative cerebrospinal fluid leaks. In fact, sealant may impair normal healing in the presence of an intraoperative leak when combined with standard reconstructing techniques with or without lumbar drainage, and therefore may in fact be something that we should not be doing routinely for intraoperative leak endoscopic intranasal surgery. Replication in other centers is certainly warranted. And again, we emphasize that the use of a standard reconstruction and selective lumbar drainage technique remain gold standards for cerebrospinal fluid leak prevention. Thank you very much, and I'd be happy to answer any questions that you have by email correspondence. Have a great day.